Okay, let's dive right into this explainer, which we've designed specifically for you guys as future physicians. Today we're going to be looking at one of the most remarkable, literally non-stop assembly lines in the entire human body, and that is hemopoiesis. We're going to treat the body's blood-forming system kind of like a highly regulated, super dynamic manufacturing plant. And honestly, understanding this journey from the embryo all the way to a fully grown adult is absolutely crucial if you want to make sense of clinical hematology later on.
So here's our roadmap for today. We'll be hitting 1. The origins of blood, 2. Inside the bone marrow, 3. Molecular control, 4. A clinical scenario looking at severe anemia, and finally 5. Extramedullary hemopoiesis.
All right, starting things off with Section 1, the origins of blood, a chronological journey. Because before we figure out how the factory works, we actually need to map out where it is, right? And the truth is, the location doesn't stay still. It changes dramatically as we develop.
Looking at this timeline, you can see how things shift. In those first few weeks of gestation, primitive blood formation kicks off in the embryonic yolk sac. But then notice how the liver and the spleen totally take over and dominate early on. We're talking from about 2 to 7 months of fetal life. It's really only in around 5 to 9 months, so just before birth, that the bone marrow permanently takes over the main production line. So, as a healthy adult, your marrow is the exclusive source of your new red cells, white cells, and platelets.
Now, what's really wild to think about is the sheer skull of this, or actually, the lack of it. A typical adult has only about 50,000 hemopoietic stem cells, or HSCs. These are the self-renewing originators of literally every single blood cell in your body. To put that into perspective, these stem cells are incredibly rare. You're going to find just 1 in every 20 million nucleated marrow cells. But because they can self-renew and divide so extensively, that tiny pool is enough to sustain you for an entire lifetime.
Moving right along to Section 2, inside the bone marrow, the factory floor. Let's zoom in on our adult baseline and see where these super rare stem cells actually live and get their work done.
When you get into your pathology labs, you're going to see biopsies just like this one, from the posterior iliac crest, and it proves a really vital concept. Notice how a healthy, middle-aged adult's marrow space is perfectly beautifully balanced. It's about 50% active hemopoietic tissue, which are those darker purple clusters you see, and 50% resting fat, those large white spaces. And definitely keep those fat spaces in mind. They aren't just dead weight. They actually represent crucial expansion room for when the body gets put under stress.
So the main takeaway here is that those 50,000 stem cells don't just float around in a void. They're supported by this highly structured microenvironment that we call the stromal niche. Just look at this cast of supporting characters. You've got your adipocytes, macrophages, bone-forming osteoblasts, fibroblasts, and the endothelial cells that line the blood vessels. Together, they secrete an extracellular matrix made of collagen and glycoproteins that essentially anchors the stem cells. It provides the absolute perfect physical and chemical environment for them to survive, self-renew, and eventually differentiate.
All right, Section 3, molecular control, managers, and purchase orders. Now that we know what the factory floor looks like, we really need to understand the management team that directs all this production.
Think about it for a second. If all blood cells, from your oxygen-carrying red cells to your infection-fighting white cells to your clot-forming platelets, if they all start from the exact same pluripotential stem cell, how does it know what to become? Who is actually giving the orders here? Well, the answer lies in transcription factors. You can think of these as the localized factory managers that commit a cell to a specific lineage. If a stem cell needs to become a red cell or a platelet, transcription factors like GATA1 and GATA2 step up and take charge. GATA1, for example, will physically bind to DNA motifs to switch on globin and heme synthesis. But if the cell needs to become a granulocyte, a different manager called PU1 steps in. And for your lymphocytes, you have managers like PAX5 and Notch1. They essentially act as the ultimate biological switchboard.
Now, while those transcription factors are managing things locally inside the nucleus, you also have circulating growth factors acting as external purchase orders, basically demanding more supply from the outside. And for red cells, the most famous of these is erythropoietin, or EPO. It's a glycoprotein that travels through the bloodstream shouting to the marrow, "Hey, we need more red blood cells right now." And this all builds into this incredibly brilliant physiological feedback loop. Step 1, an oxygen sensor in your kidney detects hypoxia, so low oxygen. Step 2, because of that low oxygen state, a specific protein called HIF1 alpha actually stabilizes instead of getting broken down like it normally would. Step 3, that stabilization triggers the kidney to synthesize and release our friend EPO. And finally, step 4, EPO travels straight to those bone marrow niches we just talked about. It binds to receptors on progenitor cells, stops them from undergoing apoptosis, and just dramatically ramps up red cell production.
Which brings us to section 4, clinical scenario, severe anemia and compensated hemolysis. Let's take everything we've established about the normal baseline, that 50-50 fat ratio, the transcription factors, the EPO loop, and apply a massive clinical stress test.
Imagine you're treating a patient with a hemolytic disease. Their red blood cells are just getting destroyed rapidly in circulation. Now, a normal red cell lives for about 120 days, right? But in this patient, that lifespan plummets to less than 30 days. So their oxygen levels drop, that HIF-1 alpha stabilizes, and their kidneys start screaming for more red cells by pumping out massive amounts of EPO.
Astonishingly, a normal adult marrow can actually expand its red cell production by 6 to 8 times the normal baseline rate just to compensate for all this destruction. Think about that for a second. The factory can scale up its output by 800%. Because of this unbelievable reserve capacity, actual anemia, meaning a demonstrably low hemoglobin level, might not even register on a standard blood test until the red cell lifespan drops significantly below those 30 days. And that is exactly what we call compensated hemolytic disease.
But how does the body physically pull off this massive output? Remember that normal biopsy we looked at with 50% fat? Well, under the heavy influence of EPO, the marrow undergoes erythropoietic hyperplasia. It anatomically expands by converting all that resting fatty space into active manufacturing zones. In children, this expansion can literally push into the cortical bone, which can actually cause skeletal deformities. And, in its desperate rush to meet demand, the marrow will even start dumping slightly immature red cells, called reticulocytes, which still have some residual RNA in them, directly into the blood circulation. So, seeing a high reticulocyte count on a patient's lab report is your big clue that the factory is working in overdrive.
Okay, final section. Section 5, Extramedullary Hemopoiesis, returning to fetal roots. Because we have to ask what happens when the factory completely runs out of space, or what if the bone marrow itself gets too diseased or fibrotic to even function?
That scenario brings us to a really fascinating, though critical, pathological state known as extramedullary hemopoiesis. When the primary bone marrow factory fails or is just completely overwhelmed by demand, blood production is forced to move outside the medullary cavity of the bones.
And this perfectly closes the loop on what we've been talking about today. In conditions like primary myelofibrosis, where the marrow gets choked out by scar tissue, or severe thalassemia, where red cell destruction is just immense, the body actually remembers its fetal origins. The liver and spleen, which we saw dominating the blood production during that 2 to 7 month fetal period, basically step back up to the plate. They either reactivate their own dormant stem cells, or they catch migrating stem cells from the failing marrow, resuming their embryonic roles just to keep the patient alive.
Honestly, it's a brilliant, albeit desperate, physiological safety net. As you continue your medical training and start encountering these complex pathologies, I really want you to keep this incredible mechanism in mind. Visualize that factory floor and ask yourselves, if the human body can revert to its embryonic state to save its blood supply when pushed to the absolute brink, what other embryonic pathways might reactivate in severe disease? Keep that curiosity alive, guys. It's definitely going to